Hey guys, okay, so in this presentation we're going to go into coronary artery disease, which is your coronary arteries are your arteries that actually supply the heart with its oxygen and its blood supply that it needs for its muscles to keep pumping. And so you can see these images here. This was actually during a procedure. You could see a blockage in that artery, so the dye isn't really going through that vessel very well. And so we'll talk about stents here in this presentation, but after it's placed, then you can see that dye is going through. All right, so we can't talk about coronary artery disease without talking about atherosclerosis, which I am going to trip up about 3 times during this presentation. I don't know what it is. It always ties my tongue. This is figure 37.1 in your book that's on the PowerPoint. So atherosclerosis comes from the Greek word ather, which means fatty mush, and sclerose, which means hard. So it's hard fatty mush, if if that's something you can take away with you. It's basically soft deposits of fat within the vessels that harden with age. It's known as hardening of the arteries sometimes. And so what usually happens is you have some sort of damage to the endothelium, so that inner single cell layer we were talking about in the vessels. It can be damaged from a few different things, right? So high blood pressure can damage the endothelium, smoking, high cholesterol, diabetes, too much sugar in the blood, infections, toxins, all of these things can damage that endothelium. And then the fatty streak will develop within that damaged area. And then it'll start to collect more, get harder, and then it can actually I'm gonna move here so you can see the image. So we have that fatty streak. It can create more blockage as time goes on. And then you can have like a clot or something that normally would go through the vessels, but because it's become so narrow and hard, it actually gets stuck in there. Because normally the endothelium usually doesn't react to platelets and clots, but because it's got these fatty streaks, it like gets stuck right there. So there's developmental stages to this. It's kind of scary when you look at some of the research for it. So fatty streaks can actually be seen in the coronary arteries by the age of 20. And those plaques start at about age 30 and then increase with age. That's when the collagen covers that fatty streak and forms a hard plaque. And then, like I was talking about, those complicated lesions, that's when something bad goes wrong, where you have like a clot or something that normally wouldn't react to the vessels, and now it's stuck there and it's actually causing a blockage. So, with our coronary arteries, they can develop what's called collateral circulation. So this is a normal coronary artery here with its normal little vessels coming out here. And our body's smart. As it starts to have this narrowing of the vessels here, it's like, I'm not getting as much perfusion as I normally do. So it starts to create these little branches, these little collateral circulation, so that it can keep getting perfusion to the heart. The problem is this takes time. This isn't like we're blocked, I need to build this. It takes a long time for this to develop. But if our patients do have nice collateral circulation, even if the patient has a full blockage to the artery, they can still get circulation around the area. But it doesn't help with like sudden clots or spasms to the vessels. Okay, so risk factors for coronary artery disease. Table 37.1, I believe, lists some of these risk factors. There's non-modifiable versus modifiable. Our incidence is highest for men over the age of 45 and women over the age of 55. That 10-year difference is usually related to hormones. Estrogen is actually very cardioprotective. So when women start going through menopause, they actually become at increased risk for this coronary artery disease. And then Once they've gone through menopause, women are actually more likely to have comorbidities and die after their first heart attack. Heart disease kills 10 times more women than breast cancer. It's actually the leading cause of death for women. And symptoms can be unspecific for women. Men tend to have I'm having chest pain, something sitting on my chest. Women tend to have I don't feel very good. So that's also why it can go untreated or uncaught. Okay, sorry if there was another pause. If you guys can't tell, I'm at home and I'm getting random distractions from my kids. So I will try and keep those breaks to a minimum if I can. So back to some of those risk factors. So hypertension can cause shearing stress to the endothelium. So that's what causes that increased risk for atherosclerosis. The big substances that we're worried about substance use will be our stimulants. So cocaine, methamphetamine, those can increase our patients' risks. And again, we want to focus on those modifiable risk factors, right? I want to tell women that they're at an increased risk and certain ethnicities that they're at increased risks. But again, it's not something that I can change. I'm going to focus on the modifiable. So table 37.2 in your book is actually great. It has patient teaching for those modifiable risk factors. So we talked about some of these with hypertension. So keeping those lipids under control, trying to keep the blood pressure under control, quitting tobacco use, getting up, being more physically active, trying to lose weight, keeping our sugars in check, reducing the stress of our lifestyle, that sort of thing. Okay, so lifestyle modifications are just what we were talking about, those non-modifiable risk factors. So physical activity, nutritional therapy. We might be doing extended warm-ups for physical activity and listening to our body. When it comes to medications, it's also focusing on some of those modifiable risk factors. So we want to do lipid-lowering medications to help with the cholesterol. Statins are the most widely used. They inhibit the synthesis of cholesterol. We also want to do antiplatelets. So low dose aspirin or 81 milligram aspirin is a big one that we'll see in patients. It shouldn't be started as our only prevention in patients over the age of 60, but if our patients are like 40 to 59, this low dose aspirin is great for them. We can use Plavix as well if they can't tolerate aspirin, or we can encourage the patients to buy the coated aspirin, like the enteric aspirin, that's easier on the gut to help with some of those GI symptoms. So symptoms of chest pain, coronary artery disease, angina is the big thing, right? Angina is a fancy way of saying chest pain. This is usually caused by myocardial ischemia. So there's some sort of atherosclerosis in the coronary arteries. And so it's causing a reduced perfusion to the heart muscle. And so we're getting ischemia to the heart muscle or the myocardium. You can have chronic stable angina versus acute or unstable. And that's the difference between an ischemia and an infarction. So ischemia is when we're not getting enough perfusion and we have low oxygen to the muscle. And infarction is when that tissue is actually starting to die from the lack of perfusion and the lack of oxygen. Stable angina occurs with stress or physical activity, and it goes away when the patient rests or reduces their stress level. Unstable will occur even if they have less stress in their life. At rest, it's unpredictable and it needs treatment immediately. And so when we're assessing our patients, we want to do a thorough pain assessment because our patients might not describe this as pain. I've heard a lot of patients say, well, it doesn't hurt. It just feels tight or it just feels heavy. And then like I was mentioning before, women tend to have even more nonspecific symptoms. Like they might be nauseous. They might have some like GI upset where their stomach's bothering them. They might be tired, or it's like, I just don't feel right. That's a big one that you hear. Our diagnostics for coronary artery disease or chest pain for that matter are these. So 12-lead EKG, cardiac biomarkers or troponin levels, and these are like particular to the heart. A lipid panel, CRP checks for inflammation, chest x-ray checks for like make sure the heart structures look okay. And then if all of these tests come back negative for an MI or a myocardial infarction, then we'll do a stress test echocardiogram. So an echocardiogram is an ultrasound of the heart. A stress test is an ultrasound of the heart once it's been stressed. And so that's also known as like a treadmill stress test. Your patients get on the treadmill, they pump their heart rate up to a certain rate, and it depends on your age as to like how fast we need to get that heart beating. And then they'll do an ultrasound to see how the heart reacts to being stressed. If the patient can't get on a treadmill, if they're bedbound, like if they're too weak or they're paraplegic, that sort of thing, there are medications that can elicit that stress that they'll just give through the IV. And then they'll do that stress echo, which is that IV medication. So our drug therapy for coronary artery disease or chest pain is nitrates. So nitroglycerin is a big one that you'll hear, like nitro tabs or nitro spray. They decrease the preload and dilate out the veins. It causes a huge drop in blood pressure. And this is much higher risk when our patients are taking drugs for erectile dysfunction. So that is definitely something we need to be asking our patients about before we give these nitrates. So Cialis, Viagra, any of those medications for erectile dysfunction, the patient shouldn't have taken it within the past 24 to 48 hours. Otherwise, it can like severely drop their blood pressure. Patients can take these at home. They can take it prophylactically even. So generally our patient education is they're going to take one of these at home, and then if their symptoms aren't resolved, then they're going to call 911. The other thing is like they can take it prophylactically to stuff that they know causes chest pain. So like if something's going to cause high stress, if they're going to go work out, if they're about to have sexual intercourse, that's another one that can be kind of a high stress activity. And so they can take it prophylactically, just not mixed with those erectile dysfunction drugs. So again, the other thing is for patient education with nitrates is it can cause a wicked headache. And it's usually because it causes that huge vasodilation. It causes that in the brain as well. And so it's like this big rush to the brain. Oxygen can sometimes help if you see these patients in the hospital. And the patients can also get dizzy from that drop in blood pressure. Other medications that we can take to help with coronary artery disease. Beta blockers help reduce the rate or the cardiac work of the heart. Calcium channel blockers help dilate out the arteries, decrease afterload. We can do ACE inhibitors, lipid-lowering drugs. Again, kind of self-explanatory with the lipid-lowering drugs, right? We're trying to prevent that atherosclerosis or the worsening of it. Eventually, these patients will need a cardiac catheterization if they have that narrowing of the arteries too much in their cardiac vessels. And so this is that first image when we were talking about coronary artery disease, where it showed the dye through the vessels. That was a cardiac catheterization. And so these are really cool outpatient procedures where they actually put sheaths in the radial or the femoral artery, and they kind of trace up the body into the heart and the cardiac, the coronary arteries. And they are able to inject dye and see in real time like how those vessels look, where the blockages are, and then they can follow that vessel to the blockage, and they put these little stents in. And so you can see the stent starts out really skinny, and then it pops open with a balloon. So they inflate the balloon and it pops open this stent, and then they remove the catheter, and that stent stays there to keep the vessel open. If you guys get to go to cath lab at all for your clinicals, it's kind of a cool procedure that you can see. And then a CABG, or coronary artery bypass graft, is another procedure that we'll use to help treat this coronary artery disease. And so this is definitely not an outpatient procedure. This is an open heart surgery. There's much greater risks. Your patient's going to be in the ICU for a few days after this procedure. And so what they do is they'll take a vessel from somewhere, whether it's it's usually the patient's calf, like the patient's leg. They'll take like a nice vessel from down there, and then they'll use it to bypass the blockages. And so this one's saying your saphenous vein graft. So this one was from the leg. So they took it and they bypassed it past that blockage. This one, it looks like they just took one from, so internal mammary artery. So that artery was already there, but it was going to the breast tissue. And so they just removed it from the breast tissue and got it past the blockage so that we're getting perfusion past that blockage. So that is what is known as a CABG, or coronary artery bypass graft. All right, that's it for coronary artery disease. In our next presentation, we're going to go into heart failure.